Once again, very warm welcome to Rebekah, senior scientist, um, really covering ADAMTS13 up at Sheffield, but amongst many other things. Rebekah, over to you.
Thank you, Jo, and thank you for inviting me this evening. And thanks everyone for turning up. It's great to see so many faces from around the world. I'm delighted to see you all. Okay, Jo, so you can hear me okay? Yep. Okay, I'm going to share now, Jo, and then if I have any problems, I'll just let you know with
You can see your screen if you just want to go to slideshow.
Yeah. Okie dokie. So can everyone see that? Yep.
Yeah.
Okay, thank you. So Jo has kindly introduced me. My name's Rebekah Fretwell, and I'm the senior scientist here working in the Haemostasis and Thrombosis department at Sheffield Teaching Hospitals. And I'm going to talk to you this evening about ADAMTS13 testing in the diagnosis of TTP. And the first photo you can see is a picture of a team I've done some collaborative work with when I went over to Japan last year in April. So more on that further on in the slideshow. Okay, so ADAMTS13, what does it stand for? So it stands for a disintegrin and metalloproteinase with a thrombus bonding type 1 motif member 13, which is quite a mouthful, and you can understand why we call it ADAMTS13 in short. Okay, there's just a bit of a delay on my moving my slides. There we go. So within the UK, within England, there are 9 specialist TTP centres, University College London, Oxford and Southampton, Birmingham, Nottingham and Leicester, Cambridge, Newcastle, Sheffield, Bristol and Liverpool. Sorry, there's a bit of a delay in my slides moving on. Sorry, Jo, I can't get them to move again.
No problem. I'll bring them up on my screen.
Shall I stop sharing, Jo, and let you move the slides?
Yeah.
Yeah, sorry, I don't know why it is. It could be the Zoom and the STH network. Okay,
Yeah, no worries.
I've stopped sharing.
I'll share them now. Can you see that? Can you see it?
So I'm on, yeah, can everyone else see it? So I'm on slide 5, Jo. Okay.
Yeah.
Okay, so I'm now going to talk you through the ADAMTS13 development in Sheffield. So for us, it started back in 2007 when we used to get these unusual samples come through for a condition called query TTP that we hadn't really heard of, and requesting a test called ADAMTS13, which again was a little bit of a new one. And in Sheffield, we're a large haemostasis and thrombosis department, and we don't generally refer anything out. But on this occasion, we were referring these samples down to University College London for Ian Mackey's group to do the ADAMTS13 testing on these patients. So it was quite a hassle to kind of, buy the dry ice at £50 a bag and get the patient plasmas, arrange for it to go down, ring UCL. And I kind of walked into the office one day and joked to my boss and said, oh, by the time I've done all of this, I could have tested these patient samples myself and given them a result. So he said to me, jolly good, though. I'll get on with that, Rebecca, and set it up. So I kind of thought, oh, I've shot myself in the foot there a little bit. So that was my that became my role to look at this ADAMTS13 testing. So by 2008, I was looking at all the commercially available kits out there at the time, which were GTI, American Diagnostics, and Techniclone, and these were looking at two different methods. One was an ELISA method, which you'll hear about lots during this presentation, and the other one was a FRET method. So I evaluated everything on the market at the time and found the ELISA method the most reliable and accurate for the patient results. And by 2009, we'd got the ADAMTS13 activity assay set up here in Sheffield using this chromogenic ELISA method. Between 2009 and 2012, lots of other centres started getting in touch with me to see if I could help them set up the test within their hospital. So I did that because there was obviously a large area to cover, and Sheffield and UCL couldn't cover everything all by themselves. And then by 2012, an ADAMTS13 antibody assay came onto the market. So we looked at that and we got that method set up again, another ELISA method. In 2017, I was lucky enough to get a grant, which I did some collaborative work with UCL, and we did a multi-centre evaluation study of ADAMTS13 activity and antibody assays within England, because by this point there's quite a lot of hospitals doing methods, and we wanted to look at the accuracy of the results being given for the patients. When I was looking into doing this in 2007, 2008, I remember one of the clinicians saying to me, "Oh, I wouldn't bother with this, Becky. You're probably only going to be testing about 2 samples a year." Well, of course, things progressed since then, and we learned it was quite underdiagnosed. And by 2018, we were doing 200 plus ADAMTS13 activity assays carried out each year, with an increasing number of antibody assays. In 2019, there was an automated method that came onto the market, and we were lucky enough to be the first in the world to get hold of this analyzer. It was called an AccuStar, and we evaluated this rapid automated ADAMTS13 activity, and I presented the work at an international conference in 2020. So up to this point, we were using the ELISA method, and the ELISA method was a very manual method. I'll show you a photo later on in the presentation, which took 4 hours or more to do the assay and to get a result at the end of it. The automated method that came onto the market was promising fantastic results within less than an hour, which was just a game changer in terms of getting patients results quickly and accurately, and of course so important for initial presentation and diagnosis of the patients. In 2022, me and another colleague went to Belgium, to KU Leuven, and worked with a scientist, Karen, and looked at an open-close work, which is another method to get ADAMTS13 activity results. And again, I'll show you that further on in the presentation. In 2022, we were doing in Sheffield 457 ADAMTS13 activity tests a year, 56 of these being for the antibody assay. In 2023, another automated analyzer came onto the market called the Sevron, which was a FRET method, and we, of course, evaluated that as soon as it was available. And by 2024, we'd got 2 Sevrons in place in the labs, and we use this and still do use this as our first line testing. And we've had full accreditation on this method 2025 and 2026. Okay, so moving on to the next slide 6. So what is ADAMTS13? ADAMTS13 is an enzyme which is a von Willebrand factor cleaving protease that specifically cleaves unusually large VWF multimers, which induce platelet thrombus formation under high shear stress. If the ADAMTS13 activity is lowered, these ultra-large VWF may accumulate within the blood, causing thrombosis due to this platelet aggregation, which may in turn lead to TTP. TTP is an acute and rare and potentially life-threatening disease, and if untreated, has a mortality rate of 90%. Clinical conditions such as pregnancy, sepsis, or liver disease may also show a reduction in the ADAMTS13 activity levels. So moving on to the next slide, slide 7. So this shows what does ADAMTS13 look like. So picture A shows normal hemostasis. And under normal physiological conditions, the multimeric size of VWF is controlled by ADAMTS13, which circulates in a closed conformation and adopts this transient, open, as it's called, conformation upon interacting with its substrate VWF. The term open and close I will talk about further on in the slide when we went to Belgium to look at that new method. So in picture B, this is a picture showing that when there is a reduction in ADAMTS13 activity within the blood, this can lead to the accumulation of these ultra-large VWF multimers, which promote the formation of these clots, which can cause TTP. So moving on to slide 8. So mild to moderate reduction in the ADAMTS13 activity levels is unlikely to contribute towards the microvasculature thrombosis, but severe deficiency leads to an accumulation of ultra-large VWF multimers in plasma and the formation of these platelet VWF microthrombi in the microcirculation. And this thrombi causes downstream effects such as hemolytic anemia, end organ damage, low platelets. So moving on to slide 9. So a severely reduced ADAMTS13 activity of less than 10. Now there's several units you might be aware of, and it depends what your hospital reports the units in. So in Sheffield, we say less than 10 international units per deciliter, but you may read this in the literature as less than 10%. It's all the same. It's the number that's important. So a severe reduction of ADAMTS13 of less than 10 confirms a diagnosis of TTP. The mortality is reduced to 10 to 20% if patients are given immediate plasma exchange. And if a patient looks as though they've clinically got TTP, this treatment should be given before the ADAMTS13 activity level is necessarily ready. So before the labs get the results, often patients are treated just because of the time aspect and the seriousness of the condition. Inappropriate plasma exchange may be administered if a quick and reliable ADAMTS13 activity result isn't available. Which is why when the automated methods came in, they were so important of getting those quick results ready for the team. And ADAMTS13 activity level discriminates between TTP and other MAHAs. So moving on to the next slide 10. The reported incidence of TTP is 1.5 to 6 cases per million adults per year, so it is very rare. In 2022, we had 11 new TTP patients diagnosed at Sheffield Teaching Hospitals, and approximately 100 cases a year, new cases of TTP a year, are diagnosed within the UK, and a few of these are congenital TTPs per year. In acute phase TTP, patients may get purpura, fever, low platelets, neurological manifestations, renal dysfunctions, hemolytic anemia, and schistocytes, which is one of the fragments you might see on the blood film, which the haematologist would look at down a microscope. And of course, TTP is very different per individual, and I know I'm talking to an audience that knows this more than me, and you all may experience different symptoms at different times, so it's quite individual to yourself. In In congenital TTP, there are mutations in the ADAMTS13 gene, and immune-mediated TTP, or ITTP, you might see it in the literature. This is an autoimmune disorder where antibodies against TTP develop, so the patients have positive antibody results. It's difficult to distinguish TTP from other related thrombotic conditions such as atypical HUS, and we test ADAMTS13 as much to rule out TTP as to rule in TTP, as it is an important test. So we often test ADAMTS13 in patients with suspected atypical HUS, and we'll find these patients would have normal levels of the ADAMTS13 activity. And of course, in patients with TTP, they would have low levels of the ADAMTS13 activity, and in first presentation, less than 10 international units per deciliter. So moving on to slide 11. So treatment of immune-mediated TTP. So therapeutic plasma exchange. This removes the autoantibodies from the circulation and supplies intact ADAMTS13 using fresh plasma. Corticosteroids, general immunosuppressors that are used for many autoimmune diseases, and these suppress not only the B cell lineage but also other immune cells. Rituximab, which is an anti-CD monoclonal antibody, caplacizumab, which is an anti-VWF-A1 nanobody, and as all the guidelines will say, start treatment strongly, if strongly suspected TTP, before you get the results back from the lab. And if the results come back and the ADAMTS13 activity level is normal, so it is not TTP, suspect atypical HUS, and it would be referred from the hematology team through to the renal team. So moving on to slide 12. So between 30 to 50% of patients will relapse, and for this reason, regular monitoring in clinic is required. Dropping ADAMTS13 levels to around 20% are treated with rituximab. That number is variant upon the site and the patient, and every case is managed individually. In pregnancy with TTP, if it's untreated, fetal loss is in 40% of those patients. And if strongly suspected TTP, treat within that 4 to 8 hour window. In September 23, recombinant ADAMTS13 was being used for the first time in Sheffield. And since we've become one of the specialist TTP centres in England, we haven't had an increase in the number of TTP patients, just really an increase in phone calls for advice and discussions around various cases. And NHS England predicts that there will be around 15 new TTP patients a year. As I say, we normally get around 11, 12. So moving on to slide 13. In Sheffield, we have 3 ADAMTS13 assays in use. We do an ADAMTS13 activity assay, an antigen assay, and an antibody assay. And I'll just briefly talk to you about each one of these in turn. So slide 14, we're going to talk about the ADAMTS13 activity assay, the ELISA method. So slide 15, you will see on screen a illustration of the Technozyme ADAMTS13 activity assay using the ELISA method, which we use here at Sheffield. This is a chromogenic test for the determination of ADAMTS13 activity in human plasma, and it uses a special monoclonal antibody, N10, and it recognises the cleavage site in the VWF73 fragments. And if you think of an ELISA, and I've got a picture of this further on, which you'll see, it's a plastic flat plate with lots of little wells in. And what we are doing is we are adding various components to the plate, incubating for periods of time. We do some wash steps where we empty that solution out and wash with a buffer in between. And then we read an optical density at the ends to give us a number of the ADAMTS13 activity in the patient's blood. If you think of it as a sandwich effect, that's what we're kind of creating, adding things layer by layer by layer. So in the diagram, it will show you the assay principle. We use an antibody coated plate. We add some substrate and incubate. We then add add the patient's sample and incubate, and any ADAMTS13 in the sample cleaves the VWF73 substrate. We then incubate with a conjugate. So these are all solutions that are used. And then we add another substrate, and then, as I say, the endpoint we read using an optical piece of technology to give an optical density and get the number to work out the ADAMTS13 activity in the patient's blood. So next we'll talk about, so we're on to slide 16. Next we'll talk about the ADAMTS13 antibody assay, which again here in Sheffield we use an ELISA method. So with the antibody assay, patient plasma is added to the ELISA strips, which are already coated with a recombinant form of ADAMTS13 protease. So in the previous method for the measuring the activity, that will take 4 hours or a little bit longer for the whole of that assay to be done and for us to be able to get a result at the end. This method is slightly shorter because we've already got a pre-coated plate. So this requires a 1 hour less incubation period. So this you're looking at 3 to 3.5 hours to get this result. So there's a series of steps involving addition of conjugate, so that's a solution, a substrate solution and a stopping solution to the ELISA plate with various washing steps in between. The absorbance is read at 450 nanometers, and this detects any IgG antibodies within that plasma. So moving on to slide 18. So blood is taken before treatment to assess baseline ADAMTS13 activity. Of course, it's really important that we on initial presentation, if it's a new case of TTP, we're doing a baseline to see what the ADAMTS is before we treat the patient. And of course, if it's a patient with TTP that is relapsing, we assess the blood before any treatment is given. So we've got a pre and a post-treatment level to see how the patient is doing. In severely reduced ADAMTS13 activity, which is less than 10 international units per deciliter, plus or minus the presence of an IgG antibody, this confirms the diagnosis of TTP. Decreased ADAMTS13 activity of less than 40 but greater than 10 is reported in a variety of non-TTP conditions, such as post-op, pregnancy, inflammatory states. So moving on to slide 19. In congenital TTP, this is a rare inherited deficiency of ADAMTS13. Of course, the activity is less than 10, and there's an absence of ADAMTS13 antibodies. So often on the report, it's a negative result that's seen. In immune TTP, this is the most common form of TTP. So patients again present with an ADAMTS13 activity of less than 10 international units per deciliter. But this is an idiopathic autoimmune disease characterized by the presence of antibodies, usually IgG, directed against the ADAMTS13. So these patients will have a presence of these antibodies, or they might be called antibody positive. So moving on to slide 20. So back in 2009, we were a long way from where we are now, and things have really developed much for the better for the care of the patients and the diagnosis. So in 2009, we had no international standard, we had no external quality assurance scheme. There was a concern that there was poor quality methods, potentially giving ADAMTS13 activity results of less than 10 in a sample which had a higher level, and potentially misdiagnosis with patients being labelled as TTP and receiving plasma exchange. And of course, plasma exchange costs thousands of pounds per day. So, patients shouldn't be having that if they don't need it. So for all of these reasons, it was so important to get this accurate assay result, and which is why we did the various studies and collaborations in England to try and see what methods were being used and what results were being given, and that we were all producing, didn't matter where we were in England, we were all producing the same accurate result in each hospital to diagnose patients. So on to slide 21. This is just an example of an ADAMTS13 referral form. This is the one we use in Sheffield. And it just collects patient details. We've actually got a more up-to-date one recently where we actually have patients' blood parameters on there as well, and clinical details, which helps us, if we're suspecting the patient's going to have TTP or not, and sample requirements for the lab. And also costs are on there as well. The cost to test for ADAMTS13 activity is far, far cheaper than the cost of treating a patient, of course. So it's far easier and to test a patient and rule it out that they haven't got TTP than it is to potentially treat them. So moving on to slide 22. So in 2019, so up to this point, we're using the ELISA method. And then in 2019, we did an evaluation of a rapid automated ADAMTS13 activity assay using a new piece of technology, an analyzer called an AccuStar. This became available. There was the mention for several years before this that there would be an automated method on the market to produce quick ADAMTS13 activity results, and it materialized in 2019. So in Sheffield, we did a study which aimed to compare this rapid automated test and compare the results to the old method, which was the ADAMTS13 ELISA activity method. And we used 205 samples to do this. So moving on to slide 23. So we used frozen citrated plasma samples from patients, 205, with possible TTP, and these were analysed using ADAMTS13 activity by both the AccuStar, the new automated method, and the old ELISA method. And based on the ELISA results, the following samples were tested. So we tested 59 samples with ADAMTS13 activity of less than 10 international units per deciliter. Of course, this is our vital group, our TTP group. Upon presentation, 76 samples with ADAMTS13 activity results of between 10 to 40, and then 70 results which were greater than 40. So moving on to slide 24. So the correlation between the two methods was really, really good. And we had a mean result of all those 205 samples of 32 for the ELISA and 37 for the AccuStar, which was brilliant. Most importantly, all 59 samples with ELISA results of less than 10, that critical range, also gave AccuStar results of less than 10. Amongst the 76 samples with the ELISA results between 10 to 40, again, these gave good results. And no samples with ELISA results of greater than 40 international units per deciliter had AccuStars of less than 22 international units per deciliter. And anything greater than 20 we consider as non-TTP. So with ADAMTS13, it's not always the number, it's the clinical significance of that number. So moving on to slide 25. So this graph shows the results we had comparing the ADAMTS13 activity with an ELISA, the old method, compared to this new automated, quicker method. And again, really, really good correlation here and really, really good results. So moving on to slide 26. So conclusions from this study were that the ELISA method was a reliable test but it did require specialist skills and was time consuming, requiring at least 4 hours to complete testing. And in Sheffield, we had a small specialist group of 4 trained scientists within our centre that were able to carry out this method. Due to the time it took to do the test, and because there was only a small group that could do the testing, this method was available only Monday to Friday between 9 to 5 p.m. And of course, patients don't always come in poorly between those times. So the new rapid automated method on the AccuStar had an analysis time of less than 40 minutes, given a turnaround time from receipt of sample to issue of result of less than 1 hour, which was just amazing. So moving on to the next slide, 27. So the new method provided better precision, lower limit of quantification, and wider measuring range compared to the ELISA method. So just generally all around, of course, it was automated, it was more accurate. And our centre became the first site in the world to offer ADAMTS13 activity testing by the AccuStar method in 2019, and we found it very suitable for routine use. And due to the technical simplicity of the assay, it allowed us to introduce the introduction of 24/7 ADAMTS13 activity service in our centre, and we were able to train up 18 staff members who were on call and were competent now to do the testing. So that meant that any time of the day or night, 7 days a week, 3:30 in the morning, whenever it is, we can test any samples that come in, query TTP, patients with TTP that are relapsing, or anything else to rule out TTP. So it's made a huge difference for the reliability and for the clinical team. So moving on to slide 28. So I briefly mentioned in 2022, we went over to Belgium to visit the KU Leuven University and worked with Professor Karen van Hoerelbeck, her lab and her team. And we worked with there's someone on there called Kazuya from Japan, and we looked at this new open close method, which was another method to kind of back up, you know, the testing we were doing with the activity levels. So moving on to slide 29. If on slide 28 we look ecstatic and excited, it's because this new open close configuration method took a week. So compared to, you know, less than an hour to get an ADAMTS13 activity result, it took us a whole week to get a result at the end. And at the end of that week, we didn't know if our result was going to be correct or not. Luckily, it was correct. And that's why we look so happy in the photos, because we didn't want to repeat it over the next week. When I was talking about ELISA plates earlier on, this is what an ELISA plate looks like. So it's a plastic clear plate with small wells, and this is where you add different solutions or patient plasmas and incubate, and then tip it out and wash, and then add more and incubate, and it's that sandwich layering effect. So moving on to slide 30. So we have had and we have several international collaborations with Belgium and Japan and the UK. And I was kind of laughing with Joe earlier, saying all our science and work and research always seems to end with food and drink. So these are just some funny photos to show you. When we was in Belgium, we ate their local cuisine, which was a stew, frites and mayonnaise, which was very nice. And when Kazuya came over to Sheffield, of course, he had to have English fish and chips. So moving on to slide 31. We then, a new analyzer came onto the market called the Sevron. And again, this was another automated method. And of course, we looked at it and wanted to look at it straight away. So the Sevron was a fully automated coagulation analyzer, and it promised to give an ADAMTS13 activity result within 25 minutes, which was amazing. So moving on to slide 32. So this just shows, so the first photo actually shows the Sevron in one of our labs, which was big piece of, quite a big analyzer. And in the photo, there's the Sheffield team, myself, Steve and Tom, but then there's two other people from the company, and one of them, Nicholas, who owns the company, came across from Vienna to show us how it worked, and we could have a play on it, and then we started using it to install it. The middle photo shows Captain Sevron. This is our lucky mascot that has to be in place at all times when we're doing any testing to ensure we get good, accurate results and QCs that are within range. And of course, the final photo shows after any day's work, what do? We go and eat and drink. So this is again in Sheffield, and I think we was at a curry place, having a nice evening there. So moving on to slide 33. So we started looking at the Sevron, and of course now we was going to compare the AccuStar results, the automated method, the old ELISA results, and now the new automated Sevron results. And what this table shows you is 10 patients. In the first column, the AccuStar column, you'll see all of those patients had low ADAMTS13 activity results of generally less than 0.2 international units per deciliter. So this is first presentation TTP. In the third column down, the ELISA column, you'll see that all the numbers are really low again. So again, confirming this TTP result. The Sevron was then tested using the same 10 patient samples, and again, it produces nice results, very low, less than 10. So all of those are in 100% agreement that those 10 patients have TTP, and all three methods match. And then on the final column, we tested in these 10 patients the ADAMTS13 antibody via ELISA, and you can see most, apart from patient 3, the rest have positive antibody results. So first presentation, ITTP, 10 samples, 100% agreement. So that was a really good start to our study, comparing all the results. Moving on to the next slide, slide 34. So here the reason we actually started looking at the Sevron, it was the new automated method on the market, and in Sheffield we like to, test whatever's new on the market to see the advantages and be aware of what's going on. But because we had found that with the AccuStar, we were starting to test, because the method was available so quickly, so reliably, we were starting to test patient groups that we'd never tested before, patients with cancer, sepsis, pregnancy, to rule out TTP. And in a very small number of these patients, we found we was getting a discrepant result. So patients, so in the column that says AccuStar, you can see that the AccuStar is giving low ADAMTS13 activity results of less than 10, which you suspect TTP. But these patients clinically didn't look like they'd got TTP. So we would then go on to repeat this test with the ELISA, the old method, and this was producing results of greater than 20. So we've got an AccuStar given TTP results, and then an ELISA given non-TTP results. And this was happening in a small number of patients, but of course, very important that we clinically got the right result. So the Sevron, we then tested on the Sevron, and this straight away started producing numbers that matched the ELISA method. And it's the ELISA results that are the correct results. So although patient numbers 34 to 40 in the ELISA and the Sevron box are different numbers, clinically, they are the same diagnosis, which is these patients did not have TTP. And when the antibodies were tested, these were all negative. There is an exception to the rule, as there always is in medicine, and especially in TTP. It is not black and white. There's always a little bit of greyness there, and that was patient 37, which produced varying results. And it's just really to highlight that in TTP, it is never black and white. So it always keeps you on your toes, and you always have to match in the laboratory results with the clinically what the patient looks like for the diagnosis to be accurate. So moving on to slide 35. So this graph shows all the results that we compared. So the ELISA, the old method, compared now to the new automated Sevron method. And again, it showed good correlation. And it showed even better correlation when we took out those discrepant results. So we were really, really pleased with that. So moving on to the next slide, so slide 37 we're on now. Sorry, this is a bit of a busy table, but what you'll see is different patients labelled as patients A to R. And there's just a couple that I want to highlight to you really. So first of all, if we look at patient C, we'll see the ADAMTS13 activity via the AccuStar, so that's in the second yellow column along. The AccuStar result gave a result of 4.1 in-slash units per deciliter. So it's within that zone of less than 10 that we suspect TTP. But we started to, after lots and lots of testing, work out that the discrepant range for the AccuStar, if we were going to hit a problem, would be any results produced that were between the levels of 2 to 10. So any results that the AccuStar produced that was within that range between 2 to 10, we automatically would repeat via ELISA. Any results less than 2, we were completely confident with our research that it was definitely TTP diagnosis. And any results greater than 10, also we didn't have a problem with. It was just this initial 2 to 10. So this patient C, 4.1 on the AccuStar, repeated on the ELISA, the old method, and it gave a result of 80, which was clearly not TTP, and the patient wasn't suspected to have TTP, it was to rule out TTP. So we tested the ADAMTS13 antibody via ELISA, and this was less than 1, so a negative result. We looked at a D-dimer. It's another test we can use, which a normal range is less than 500, and this was nearly 20,000. Another test we used was antithrombin. So really it's trying to get all that information together to accurately give the clinicians as much information as possible to put with the clinical symptoms to see has that patient got TTP. And of course these results suggest not at all. And the patient's clinical presentation was post C-section, low platelets, confusion and deranged liver function tests. And the diagnosis was HELP syndrome. So definitely not TTP. If we now look down at patient I, so we can see this patient on the AccuStar gave an ADAMTS13 activity of 6.4. So again, it's within our range that we're not happy with. So we automatically repeat on the ELISA, the old method, and that gives a result in the third column along, you'll see, of 48 in-slash units per deciliter. The next column you'll see we test the ADAMTS13 activity antibody and we get a negative result of 2.7. So anything up to 12 is negative, 12 to 15 is borderline, and greater than 15 is positive. So that's a negative result. We then test a few more, you do a few more tests to see if we can get a bit more information. And of course, this patient has got high D-dimers, 65,000 now, low antithrombin, low platelets. The morphology on the film suggests fragments, and the final diagnosis of this patient was metastatic lung cancer. So again, definitely not a TTP patient. And the final one I'll just highlight is patient R, which is the last one at the bottom. So this patient had an ADAMTS13 activity on the AccuStar of 9.5, so still within that 2 to 10 range that we're not happy with. And when we repeated this on the ELISA, it gave a result of 43.6, so not TTP. We tested the antibody, which was negative at 3.5. We looked at D-dimers, which were mega high at 600 and nearly 630,000, low antithrombins, and the final diagnosis for this patient was sepsis. So that's really just to show to you, there can be other conditions that we're looking at when we're doing our diagnosis. So moving on to the next slide, slide 38. So when we were looking at the method discrepant groups, in first presentation patients with query TTP, we tested 645 patients with a patient range results of between less than 0.2 and up to 148 international units per deciliter. 63 samples had ADAMTS13 activity results of less than 10 international units per deciliter. And we found 44 samples had results of less than 1.2, and actually 30 of those samples had results of less than 0.2, so definite TTP. So moving on to the next slide, slide 39. Of the discrepant group, 18 samples had results between 2 to 10 international units per deciliter. One of these was a congenital TTP patient, genuine, and 7 of the 17 other samples, 14 was shown to be method discrepant, with AccuStar ranges of between 2 and 9, which repeated on ELISA came out between 22 and 80. 3 were low, 1 was congenital TTP. So really, to summarise all of those numbers up, of the 645 samples we tested in this study, we found 14 patients to be within that discrepant range, which equates to around 2%. So it was a very, very low number, but of course that number still needed to be calculated for. So moving on to slide 40. What we found within that discrepant group, the 2% discrepant group, was that their D-dimer levels, that's another test used, was significantly raised, up to 629,000. And in the ITTP group, they can often be raised at presentation, but we're talking 346 to 43,000, certainly not as high levels as was getting within the discrepant group. Within the discrepant group, the antithrombin activity was reduced, whereas what we find in ITTP patients is they normally have normal antithrombin activity. So all of these results together suggest there was an interfering substance that was producing this discrepancy in patient results. So moving on to slide 41. I was lucky enough last year to be invited over to Nara Medical University Hospital in Japan last April to give various talks and seminars to the Japanese group about the work we did over here in Sheffield and the different studies we'd done. And you might notice on that photo Kazuya, who I did some collaborative work in Belgium with a couple of years previous. So it was great to go over there and work with Kazuya's team. So he's a associate professor and a hematologist, medical hematologist. So it was great to see his hospital, the professor next to me on the left-hand side, who is his boss, who he works with, and their hospital, their site, their laboratory, and how in Japan they diagnose TTP patients. And what was really interesting was the remit for me to go over was to try and convince them that the automated method was safe to use. So all of their ADAMTS13 activity patients are tested via the ELISA, the old long 4-hour method. They don't use any automated methods at the moment, and they are wanting to move over to that automated platform. So I took all the data over and basically tried to convince them. We've done hundreds and hundreds of patients. It is safe to test them, and you'll be able to give patient the results much quicker if you do it on the automated method. So that's the team. Of course, we went for food. You'll see there's a food photo in there. Moving on to slide 42. So this is showing you photos of in Japan, their hospital setup, the laboratory, the analyzers they use, which is really interesting to see. moving on to slide 43. I was also lucky enough to be invited to Sysmex Corporation head office in Kobe, Japan. Sysmex is a company we use in hemostasis, a big company we use in hemostasis. And again, I presented my work and research and everything. And yeah, really interesting to hear their work and what they're doing over there. And yes, I would love to work in a place like that. They had Japanese gardens and therapy rooms for their staff to relax in at lunchtime, and meditation rooms, and yeah, a different world. So that's a few pictures showing the lovely site they work on. And of course, they took us for food at the end. So this is the Japanese group taking me out for some sushi. So moving on to slide 44. So now just a couple of patient case studies. So first patient, Friday afternoon, which our patients always seem to come in on a Friday afternoon. I don't know why. And there was 2 patients with the same name in the same village. I mean, the chance is pretty rare, but one had ITTP, we found out. So patient had and both had low platelets. So patient had a fall in platelet count. An urgent ADAMTS13 activity was requested and sent to Sheffield. We tested it straight away on the AccuStar, the automated method, and we got a result of 0.3 international units per deciliter. So that's a result of less than 2, genuine result. We were happy that was TTP. We repeated then the antibody on the ELISA method, and we got a positive result of 21.4. So the patient was brought straight in urgently, plasma exchange that evening, and it just shows that without the new technology and the way things have progressed over the years, without these automated methods, we wouldn't have been able to do any testing until Monday morning. And of course, if the patient wasn't treated, then that could have been fatal. So it's so important to get technology moving all the time and new methods to be evaluated and the most accurate methods to be used. So this is a new diagnosed TTP. Patient was plasma exchanged and yep, doing really well. So moving on to slide 45, another case study. So this was a patient that was a C-section patient. They had a ADAMTS13 activity on the AccuStar of 4.1 international units per deciliter. So straight away, that's within our discrepant range that we are suspicious of. A negative antibody, and when we repeated this on ELISA, the old method, it was 80. So this patient did not have TTP. So to conclude, any ADAMTS13 activity levels of less than 10 or undetectable are diagnosed with TTP. In acute TTP, the activity of less than 0.2 on the AccuStar and less than 10 by ELISA, we have had 0 instance of discrepancy. Activity levels between 2 to 10 on the AccuStar could be discrepant in a very small number of cases, around 2%, where on repeat, the ELISA results give a higher value. Activity results between 2 to 10 in first presentation, query TTP. We always say any kind of guidance would be view with caution to the laboratory team, to the clinical team, view with caution and review within the correct clinical context. Also do an antibody and also repeat with a secondary method via an ELISA or a FRET method. That's what we do in Sheffield. Anything less than 10 is fine. 10 to 15 we call the grey zone, and any activity results of greater than 20 is not TTP. So what this shows is that the activity, method and clinical context are very important in diagnosing this disease. So moving on to slide 47. The introduction of the automated methods has allowed increased accessibility and rapid diagnosis. We have had an increase in testing in patients with underlying conditions such as sepsis, DIC, malignancy, pregnancy, and 40% of our discrepant cases have actually been patients with cancer or sepsis. And this is just because more patients can be tested now because we've got such a quick turnaround to rule it out. In cases where clinical presentation supports TTP, the AccuStar has a valuable role in diagnosing and treating TTP, and in these cases there's a good correlation between the results on both methods, the AccuStar and the ELISA. And 95% of all testing can still be carried out on the AccuStar, which is also able to do other tests within a hospital. But other methods are needed to diagnose that small discrepant patient group. So moving on to the next slide, slide 48. And final conclusions. The cases of the method discrepancy were all described and presented at international conferences by the TTP working group and have been published in current guidelines, British guidelines. Guidelines to healthcare professionals states that where there is clinical suspicion for TTP, be careful when interpreting low ADAMTS13 activity results that are produced on an AccuStar, as these may show a positive, a false positive ADAMTS13 deficiency of less than 10. And to avoid misinterpretation of discrepancy, always confirm these samples with a secondary method. So my final conclusions are: ADAMTS13 activity testing is not straightforward. TTP must be diagnosed with the correct clinical setting with a reliable and accurate ADAMTS13 activity result. And ADAMTS13 activity levels affect TTP patients very differently and vary so much. So each patient is treated individually by their clinical team. And I know, speaking to TTP patients, patients can walk around with low ADAMTS13 activity levels in their boots and still feel well, and other patients can recognise when their levels are starting to fall, getting headaches and different symptoms, which of course you'll all know far better than me, but you all do seem to have very, very different symptoms at different levels, which makes it very complex. So moving on to slide 49, this is just thank you to my coagulation staff at the Royal Hampshire Hospital in Sheffield. That's on our tea break. Kazuya is also in that one. He gets in a lot of our photos. And then thanks to the team. And finally, if you do have any questions, I'm happy to take any questions now. But after this, if you think of anything, that's my email address. More than happy to take any emails from you. Thank you.
Thanks, Rebecca. That's brilliant.